I think we are live, right?
I think we're live. How was your day?
It's just quite exciting and nervous regarding the technology, but you are so good at this magic stuff that everything is connected, I think.
Well, partially we had 4 microphones, 3 filled, and so we just have this one.
Yeah, but hopefully this will work. Hopefully everybody who is watching us online can hear us very well. We would like to welcome everybody who is here offline, let's say it. We will make, yes, Christian, is everything? Yes, we will.
Working. Can the people backstage do a thumbs up if they can hear us? Yes, I see a thumbs up from Evert from online backstage. We have a real backstage and an online backstage.
Yeah.
I think 1 more minute. Do we have like a countdown?
Just now it's 7 p.m. so we can start.
In my laptop says 1 minute, but in Poland apparently it is already 7. Good evening, everybody. Welcome for this second event of the different thematic communities events per month with a different thematic community in a different European country, live from the country and streamed on Volt Europa YouTube. My name is Christian Meinsma. I'm working as the thematic community coordinator from the European Community Team, and we're here to talk about healthcare, healthcare across Europe, doing healthcare completely different, and especially, I think, mental healthcare in Poland, I believe. And Michał.
Yeah, thank you. This is correct. My name is Michał Terpiłowski. I'm co-leading the community that Christian is helping me start, the health community of Volt Europa. I'm also community lead at Volt Poland. And I'm also very much into mental health balance. It is like my niche. I have foundation which is like focused on promotion of mental health balance. That's why actually this idea came to our mind to make such event. And I'm really happy that we can co-create it. And I think we will start like do you want to say something else, or would you like to start?
Yeah, to walk you through a bit through the agenda. First, we'll have an opening presentation by Evert to set the scene a bit. Then we'll go into a deep dive presentation on looking at a citizen research project that's, I believe, still ongoing, but the presenters will tell you way more about it, on comparing different healthcare systems in Europe. Then we have Ushma from Ripple, who will present another way of looking at healthcare. I believe it was healthing. It's an amazing new approach to look at it. And then we'll have a panel discussion with some of the amazing people here on potential change on mental health care policy in Poland, right?
Yeah, the mental health reform, which is already taking place since 2017, with some problems and some hopes. So there will be Rafał and Norbert from FKOPKA Foundation, with whom I will sit here and ask them difficult questions.
I'm already excited for the difficult questions. And last but not least, we have 2 new guests who will join online. They will be, this is Madalena and Sue. Madalena works as policy shaper in the European policy team of Volt on healthcare. And Sue, who will pick up the co-leadership role with Michał of the Volt European thematic community on healthcare. They will reflect on everything what was discussed and see what we as Volt can learn from this and really take forward in improving healthcare and health for everybody in Europe in the upcoming years. So I think let's get started. And I will now go to the computer.
I'll take the, I can tell some bad joke, like, do you know what's the favorite food of Beethoven? Banana. That's the end of the jokes that I have for today. But now I will leave the floor to Evert.
Okay, and now I see the slide from Ripple, so that is not my slide.
Should I mute the mic here?
That is better. So now you should be able to see my slide, right?
Yeah.
Okay. I cannot see you anymore, so if something goes wrong, you need to shout loud to me. If I don't hear anything, I will continue. I have about 10 minutes for a story that usually takes up more than an hour. So I condensed it to take you to the main elements. And my basic message is that, well, at least in the Netherlands, but I think it will count for other European countries as well, we have a healthcare system that can be characterized as mopping with the tap open. I have this cartoon in mind about this, but I'm terrible at drawing. So I asked ChatGPT to draw a cartoon for me, and he almost nailed it. There are some errors in it, but it's still, I think the message gets across. This is what we see in the healthcare system. People are mopping like hell, and there are policymakers and etc. who are shouting that the mopping needs to be increased even more. And we keep the tap open. So in my view, what we need to do is start thinking about how can we close the tap. The difficulty with closing the tap is that you need the people who it is all about for that. You cannot do that as organizations for the people. So if we want to close the tap, we need to make a shift in our institutions to start working with people instead of working for the people. And this is a very difficult task because organizations by default are used to working for the people. And that has to do with the fact that organizations traditionally work top-down. That means that the organization decide what to do, and the people who it's about, where they're working for, they need to, they have to just to accept how things are going, let it go. More and more I see, especially with the municipalities I work with, I see that they tell me that this doesn't work anymore. And then they tell me they need to make a shift to working bottom up. And nobody seems to realize that working bottom up has exactly the same problem as a top down, only the different way around. So in the case of bottom up, the bottom is deciding what to do, and the institutions have to accept what is going on. So they look at it, and if they don't like what is happening, they will intervene again in a top-down manner. So to break through this dynamic, we need a third model. And that model, in that model, top and bottom together decide what to do, and also together execute that. And this mechanism is called community up. And the basic idea behind this name is that the institutions should become part of the community. And then you get real cooperation where the two sides really strengthen each other. Now, to look a little bit more detail into this, I like to use this model, which was created by Cormac Russell. Cormac Russell is the driving force worldwide behind an approach called asset-based community development, ABCD. For those who have never heard of it, I suggest that you take a look at it because it's really interesting stuff. But unfortunately, I don't have the time to dive deep into that. So I will stick to using this model from Cormac Russell. And he distinguishes things that are done by the neighborhood themselves, things that are done for the neighborhood by the organizations, and in the middle you see with the neighborhood, where organizations work together with people from the neighborhood. And typically when you look at this, at the upper left part, you see the neighborhood has a lot of experience about what it is to live in that neighborhood. And they also have expertise because the people living in the neighborhood, they had education, they have jobs, etc. And then on the other side, you see the organizations, they have a lot of expertise, but they also have experience because those people working in those organizations, they also live somewhere. Now, the basic idea with community up is that you take the two sides of experience and expertise and combine that into solutions, joint solutions, that are executed with the neighborhood. And this is the ideal situation, what you would like to see with Working Community App. Unfortunately, this is a very infrequent occurrence. You hardly see this. And why is that? That is because organizations tend to transform their expertise into offerings. And I always call offerings canned expertise. It is expertise that is packaged. It has taken a fixed form, and that makes it impossible to connect with that knowledge. And as a result, those organizations build a wall around themselves, which makes it impossible to get to those joint solutions, the solutions with the neighborhood. Let me give an example. We worked in a neighborhood, the poorest neighborhood of the Netherlands, called Moerwijk in the city of The Hague. And a municipality wanted to tackle obesity, obese in that neighborhood. And they came with this offering, this idea, and the idea was to use the CLI, which stands for Combined Lifestyle Intervention, which is a program of 2 years where people are supported in changing their lifestyle. And it's part of the health insurance. So everybody in the Netherlands has a health insurance, and the whole CLI offering is paid out of this the health insurance. So all the people in the neighborhood, what they had to do was go to the general practitioner and request a prescription for this CLI program. Now, what turned out, the people in the neighborhood did not go to the general practitioner. They did not get the prescription. So what did the municipality do? They assigned a CLI coach, a person who had to get all those people with obese in the neighborhood, Moerwijk, to get to the general practitioner. And what happened? Still, they didn't go there because it was absolutely not in their idea. There wasn't good solutions for them. So what did we do with this community upworking? We got people from the neighborhood and people from the municipality and people from care organizations together to brainstorm about how can we solve this problem of obese. And in the end, they came up with a total different idea, the idea of a Moerwijk cookbook. So a book with all kinds of recipes that people can use to create healthy meals for themselves. And the idea behind this is that people don't have much money in that neighborhood. And often healthy meals are quite expensive. So this cookbook contained all kinds of recipes to create cheap, healthy meals. Now, this is a typical community up solution. Another example of a community up solution that ties to the thing that we're talking about today. A lot of people in the Netherlands, or at least in the city of The Hague, who have mental problems and for a while stay within some kind of care organization, after a while they get better. And then they have to get back to society. And most of those people end up in the Moerwijk neighborhood, which is not a very nice neighborhood for people with mental issues to get there. The health organizations had been thinking a lot about this, but could not find a solution. So what did we do? We put people from those organizations together with the people in the neighborhood and also people in the neighborhood who had mental issues. And in the end, the latter, they said, as a solution for this, they said, we would like to be someone we have missed ourselves. Several years ago, when they returned into this neighborhood, they felt very alone, having to deal themselves with this difficult situation. And in the years that had passed, they had found ways to deal with that matter. And now they said, we are ready to support the people that enter with these mental issues in our neighborhoods. We are ready to support them and to make their search for how to handle this much easier. And this is a solution that the professionals would have never thought about. And that is the main idea about joining those different expertises and the power of community up working. What this requires is a real conversation, based on equality conversation between the different people. And this is something that a lot of institutions have much difficulties with. When we started our project in Moerwijk, which was focused on finding a way how people from organizations and people from the neighborhood could jointly build a healthier society, the municipality came to us and asked us, how do you get in touch with those people in the neighborhood? Because that is impossible. Now, we never have any issues, and in this case, we used an approach which are called the tangerine talks. So you take a bowl with tangerines, you put ice on those tangerines, and then you go to, for instance, a school in this case, and you ask everyone who is walking by, would you like to draw a mouth on the tangerine, a happy mouth if you feel healthy, and a sad mouth if you feel unhealthy. And as a result, you have a 10-minute low-level talk about the health of those people. And after that talk, people are willing to do an interview with you, to go more in depth. Because at that stage, you have shown that you have an interest in them, instead of what most people from municipalities do, talk with those people about the solutions that the municipality has. So it is this type of elements with which you can create icebreakers and start the real conversation. I will end my presentation now with the more overall approach that we use, where those tangerine talks were part of, which in our experience is very effective in firing up this community up work. And that approach is called participatory action research. And that consists of 3 phases: the look, the think, and the act phase. In the look phase, what you do is you talk to people who have some kind of stake in this. So in our case, when it came to health in the neighborhood, it was obviously the people living there, but also people from the municipality, people from the housing association, all kind of organizations who have something to do with touches on health in that neighborhood. And we interviewed them to get an idea of their perspective on the issue of health in the neighborhood. So what problems do they see? What solutions do they see? What can they contribute themselves to get to the solutions? What assets are available within the neighborhood? And you get all those perspectives together, and then in the end of this phase, you create visualizations in which you show the different perspective and how they relate to each other. And then in the next phase, you don't go and start think of a solution yourself, but you take those visualizations and you bring together those people that you have interviewed and show them the visualizations and let them reflect on it in a dialogue. And what happens then is that the people, they recognize their own perspectives, but they also see the perspectives of others. And by having this dialogue about that, people discover how the ideas of someone else can improve their own ideas. And that is how you create what we call a feeding ground for co-creation. And that is what we do in the last phase. Then we get those people together to actually create plans, co-create plans to solve the matter. And because they had the dialogue before that, they have discovered how they can help each other, which makes the co-creation much easier than if you start with co-creation right from the start. This is a very quick description of how I view the health system, how we can change that by shifting from working for people to working with people, and especially using this approach, participatory action research, to fire up community up working to get that done. This is what I wanted to present to you.
Thank you, Evert, for setting the scene on already thinking a bit differently on healthcare. Thank you so much for this enlightening presentation. In the meantime, we solved a tiny technical issue because the comment section was not on. That is live now. So if anybody of the listeners and viewers at home want to ask questions, you can put them in the comment section. Now, to continue with the program, Evert already mentioned different types of healthcare systems. We are now actually going to deep dive a bit in the different type of healthcare systems, and therefore I'm now bringing our next two speakers on stage. That is Thijs and Tom. Welcome to the stage. Thank you again, Evert, and we'll continue with this presentation series on healthcare in Europe. A big round of applause for Evert. You can introduce yourself a bit, and you're now live. And yeah, tell us more about the different healthcare systems across Europe. And I believe you did this in the context of a citizen research project of Volt Charge. So it would also be amazing if you could tell us a bit more on that. The floor is yours.
Absolutely. Thank you, Christian. And thank you all for joining us today. Thijs and I are very excited to join you in this broadcast live from Amsterdam. And perhaps to start, like Evert Jan just mentioned, good healthcare requires participation of citizens. And that's why we want to present to you today a project that we've been working on at Charge, research platform Volt. So I think it'd be good to start off by telling you a little bit about Charge. Like the title already mentioned, Charge is the research platform for Volt Netherlands. It was founded in 2023, and it positions itself as the knowledge broker for Volt. Charge focuses on two main themes, which are democratic innovation and European integration, and it does so by executing, supporting, and fostering research within the larger Volt organization. Now, we at Charge believe that great research prioritizes social engagement. So that does not only mean that it should aim to be relevant and to capture trends across an entire society, it should also spring from society. As you all know, Volt is a grassroots movement, which is why we also wanted to design a research methodology that is grassroots and aims to include perspectives across the societal spectrum. Luckily, we did not have to reinvent the wheel there because there already exists a term for that methodology, which is citizen science. Now, citizen science refers to the scientific research conducted by citizens, non-professional scientists, essentially, as a way of involving the public in science, and with the eventual goal of making research more inclusive and socially relevant. Now, our vision is that there should be a central body within the organization that fosters and supports citizen science, to then empower Volt in generating evidence-based policies that are inclusive and also reflect what communities are actually experiencing. However, lots of questions and hurdles still remain. For instance, where do you find the citizens to conduct this research? How do you come up with research subjects? How do you ensure that the quality is maintained? And what should be the final product? Should it be a report? Should it be perhaps a podcast? And how do you really structure the process in such a way that you also have realistic timelines? Now, so to answer these questions, we decided to run a citizen science pilot program, essentially to extract learnings and come up with guidelines so that in the end, everyone at Volt can start doing citizen science and support Volt's knowledge base. So we decided to run this pilot program with a group of volunteers that were already involved with Charge at the time, shown on the bottom of the slide here, which are Diederik, Bart, Thijs, who you also see on the screen, and myself. Now, before we proceed and tell you about the research we've been involved in, I would like to quickly give you a little taste of what our pilot program actually looks like, which is on the next slide here. So we've structured the pilot program to run for 9 months. And these 9 months, we start off with sharing ideas and concepts within the group to come to a research topic and research question to really spend the next 9 months on. We then spend around 2 months to get accustomed to the topic, read and collect relevant literature that will help us, answer these questions that we've set up. But of course, this step may also include gathering data, perhaps conducting a survey. It's essentially the period through which you gather evidence to start answering research questions. And that's exactly what we do in the next phase, which is the analysis phase. And during these 2 months, we sit down, we analyze literature, we analyze data, and we essentially generate insights that will help us answer the initial research question. Now, for the final product of our pilot program, we decided to draft a report, which is what we focus on in the next phase of the pilot. We spent approximately 2 months to get to a first draft of the report, which we can then distribute to experts in the field and gather feedback and input. And then for the last 2 months of the pilot, we gather all of the feedback and inputs, and we work towards a final draft of the report that we should then be able to publish through Charge's channels. At least that's the plan. Now we're currently here. We're finalizing the analysis phase. We're getting ready to write down our conclusions and work towards the first draft. It's been quite a ride up until now, and we're still far off the finish line, but we have made enormous progress, and I am personally very optimistic about the potential for citizen science within Volt. I'm therefore very excited that we will hopefully be able to share our methodology with the rest of the organization later this year. However, you might also be wondering, how is this relevant to the conference today? Good question. The matter of the fact is actually that we are currently researching EU healthcare systems. So we thought it'd be a great opportunity for us to share some of the things that we've learned thus far. And now, as part of our research, we've looked into the EU healthcare systems, their histories, and how they compare. And I would like to hand over the baton to Thijs, who will be able to tell you a little bit more about that.
Yes, thank you very much, Tom. Yeah, so I will dive into our study immediately. And our introduction kind of starts with a big reform in the Dutch healthcare system in 2006, where the government really wanted to increase competition to get more efficiency and lower costs. So what they did was that they moved away from a government-regulated insurance system to a privately owned insurance system. Now, roughly 2 decades later, the evaluations are pretty mixed. On one hand, you can see that the efficiency actually in general went up. However, the cost also went up by a lot, and especially the out-of-pocket expenses went up significantly. And this example kind of shows that big changes in healthcare systems can have unforeseen effects. And with the study we are currently doing, we really want to get some deeper insights into the healthcare systems on a macro level, and to see if we can identify trends and see if we can determine best practices where we all can learn from. And also then with this information, we could maybe decide whether the change in a system is actually worth the cost and the effort. But healthcare systems, how did these kind of develop in Europe? So Can you go to the next slide, Tom? So in the late 1800s, Germany actually started the first healthcare system. And what happened there was that workers, they were very unhappy about their healthcare situation. So they went on strike, and together with the employers, they found a way how to get better healthcare. And what they did was together they would put money into an insurance fund, and the insurance fund would pay out money when the healthcare worker would get sick, so that the healthcare or that the worker would be able to get appropriate care. And this system was really groundbreaking in Europe. Then in Eastern Europe, a different system evolved a bit later. And this also evolved because of unhappiness within workers. So this system was way more centralized, where the government was financing it and the government was also delivering the care. Then many years later, the UK also shifted towards a system like that. However, the UK system was a bit less centralized and is now known as the Beveridge model. Then post-World War II, a lot of countries started to also set up systems. And what they did was that they used pieces from these three early models to tailor their healthcare to their specific needs. So it is pretty difficult with all these mixed models to compare them. So in literature, we really had to get an understanding or look for the structural components within the healthcare systems. And from the papers that we read, we kind of identified three major pillars in the healthcare system that can address kind of the core functions of any system. So the first pillar is regulation, and regulation is, of course, essential for setting standards and rules that govern healthcare systems. Then the second pillar is financing. So, there you already from the previous slides, there were differences in financing. One is more government finance and the other is insurance-based. So this is also a really interesting pillar to look at. And then you have the provisions, and the provisions is actually the question, who is delivering the healthcare service to people? So does the government own a healthcare facility, or is it the private sector that owns the healthcare facility? And with these three pillars, we sought to categorize the different systems in Europe. And when we did that, we came, we categorized them in the end in 4 ways, as you can see here. And I will walk you through this schematic. So on the top row, you see the National Health Service, and this is what they have in the UK, but also in other countries in Europe. And here you see that the regulation is done by the state, the financing is done by the state, and the provision is also done by the state. So you can see that the state is really involved in every step. Then the next category is the National Health Insurance, where the regulation and financing are both done by the state as well. However, the provision is done also by private institutions. So you have private hospitals or private outpatient care facilities. Then the third category is the ETESTIS, social health insurance. And here the regulation is still done by the state, but the financing is done in a more societal way. And this kind of means that there are insurances involved in different flavors, but there is an insurance involved where, for example, an employer pays to an insurance company who pays the healthcare system. And here you can also see that provision is done in a private way. Then the last category is the social health insurance, where the main difference is that the regulation is done in a societal way. And this means that not only the state is weighing in on the rules, but there is also other organizations that can weigh in on the rules. For example, NGOs that consist of healthcare professionals or different NGOs, those kind of things. And here you also see that the financing is done on a societal level through insurances, and the provision is also done on by private institutions. Within these categories, there is still a lot of different flavors, but we try to at least make a division with the European countries. And if you then look on this slide, you can see this division. So on the left side, you see the attested social health insurance system, where we, for our research, made a division between the traditional ones and the Central and Eastern European ones, because we saw in our research that there is still some differences between those, especially in the financing, and I will come back to that later. Then in the middle, you can see the countries that are in the social health insurance, and on the right, you can see the countries that are in the national health insurance or the national health service, both very much governmental-based systems. If we then take a deeper look into these systems and we look at the build-up of their healthcare budgets, we see some pretty interesting things. On top, you see this line where you can see which country belongs to which system. And then on the left side, you see the national health system and the national health insurance. And when you look down into the bars, you see that these countries compose of very large bars of the dark purple color, which represents government schemes. So this makes sense with our previous categorization, where government is the main financer of these systems. Then on the right side, we had the societal systems. And here you can see way more dark gray bars, which are health insurance schemes. Then I said we made this division between the Central and Eastern European systems and the traditional ones. And here you can clearly see a difference in the out-of-pocket payments. And we see that these out-of-pocket payments are, for example, in the Central European countries are way higher than in the traditional attested system. Then Tom will give you a little sneak peek of what we can do with this data.
Yes, thanks, Thijs. Now, so I've already shown you what's next for us in the Python program in the timeline I showed you before, but I'd also like to make it a bit more concrete. Now, so one of the goals of our research is to extract insights by comparing EU healthcare systems that will hopefully eventually help us improve individual healthcare systems. So essentially, we're asking ourselves, what can we learn and improve by looking at each other's systems, right? Now, we all know there exist disparities within the EU that allow some countries to spend more on certain things than others, including healthcare. That is also why healthcare systems like the Dutch one, I don't like to brag, but like the Dutch one, are known for their high quality. However, we have purposely focused on cutting through the noise and trying to focus on the things that you cannot solve by simply throwing money at it. Like, for instance, the example on this slide, which are healthcare waiting times. Now, it's perhaps a bit counterintuitive, but it's a lot more expensive to manage healthcare systems that have long waiting times than those that have short waiting times. The explanation is that waiting times cause people to become more sick, which is expensive. Now, we actively look at or for healthcare performance indicators like these that show a somewhat random spread when you map them against healthcare expenditure. And these are great because you can ask yourself the question, why does a country like Switzerland, who spends almost 3 times as much on healthcare as Bulgaria, score equally well when looking at waiting times? And how does Bulgaria structure its healthcare system in such a way that waiting lists are very small without having to spend a lot of money on it? And then what trends can be identified by looking at the healthcare category level, because we've also plotted these out in these different colors. How does the way you structure your healthcare system in a macro sense influence certain performance indicators like waiting times, but also quality and accessibility? Now, these are all important questions that we're currently trying to answer with the goal of deriving insights that we can use to build better healthcare for all. Now, if you want to be notified when our report is published or want to know more about citizen science or Charge, be sure to reach out to us or follow our socials by scanning the QR code on this slide. And with that, we want to end our talk and, of course, answer any questions that you might have. Thank you.
Thank you, Thijs and Tom. And I already heard some applause here from the people here in person in Poland. And I already saw them looking when the PL of Poland came on the screen. Question to you, as we're now talking here, for example, also with Poland, did you see, I know that you're early in your research, an example of what, for example, the Polish system does well?
Yes, so let me, in the meantime, gather all of our, so we have a great big data room with a draft. Well, I think that in general, Poland scores pretty well within its own category. I think it scores really well within the EU healthcare domain in general. We are looking at things like accessibility, where Poland scores quite well in terms of travel distance, which is not only due to its geography, but also looks at the spread of healthcare facilities throughout the country. I don't know, Thijs, do you remember any?
Yeah, I think here it's mainly important to plot it against the expenditure of the healthcare system, and then you can really make very nice cutoffs where you see that some Western European spend twice or thrice as much and are at the same level as Poland. So that is indeed for the travel distance, for example, but you also see it here for the waiting time. So those are really interesting things to keep in mind. With our study, we really try to not focus too much on one country, but we want the readers to do that themselves. So once it gets out, everybody that's excited about their own country, can really dive into that.
Thank you for the answer. And again, we know that it's an early stage in the research, but I saw here already on your what's next for us slide an interesting dot, because oftentimes if you look, for example, towards US and Europe, US always claims that oftentimes the European systems is probably you have very long waiting times, for example. And here I actually see, correct me if I'm wrong, Hungary with relatively, like I think the lowest, relatively low waiting time and a low expenditure on healthcare. Do you maybe already have an initial explanation on that?
Yeah, so it's unfortunately it's the other way around.
It's
a waiting time score. So the higher the score, the better you perform. So Hungary is actually one of the worst ones. But yeah, as you said, they also don't have that much money to spend.
Romania, Bulgaria, right? Has high, quite.
Yeah. And what you often see, there's this sort of double-edged sword where when waiting times are long, healthcare systems might focus more on long-term patient care. And you see that, for instance, also with Bulgaria, very short waiting times. Everyone can access a doctor when they want to. But long-term care really is not quite that good. There's not a lot of resources for that. So it's sometimes a bit of a balance. That is something you often do not really see with systems like the Swiss one, because they just have large budgets to spend on that. But it could be the same case for Hungary.
We already also have good online participation with questions in the comment sections. And again, we know you're early in the research, but what would already be from your initial ideas an towards an optimal systems? Which design choices okay might not make the most optimal system, but near, let's say, suboptimal? What are already key components?
I find it very difficult to say because I think there's also a huge political or political philosophy behind the systems. As I said, you have either this state-based financing or the insurance-based financing. What I think, and that is maybe a personal opinion, is that with the insurance-based financing, you have a bit more buttons to push. So you can tailor your system maybe a bit more to the needs of your country. While if you do the financing in the government or from the government, it's always a bit more rigid and a bit more bureaucratic, and it's less easy to tweak. But that is maybe also a personal opinion.
Yeah, and what Thijs mentioned there, the fact that it's tailored, I think that's something that is important for every healthcare system. It should really be tailored to the specific country and their specific needs. You see that, for instance, in Norway, which is a very geographically spread out country, still has one of the best or lowest traveling distance for patients to their closest healthcare facilities, which is sort of counterintuitive because it's a very big place. But they've organized their healthcare system in such a way that a lot of responsibility lies at the municipal level, which allows the municipalities to structure their system in such a way that it accommodates every patient. So I think that it being tailored to the specific needs of a country is something that is always ideal.
Tailoring still to the need of the specific countries. We are again here with Volt Poland, and we also have a question here from the room for you.
Hello, thank you for your interesting presentation. And actually, I have two questions. One is about this interesting methodology, citizen science. Where can I get some more information about this methodology? It's very interesting and new one. And the second one is more connected with substantial side of the presentation. I mean that did you consider the impact of the migration as one of indicators of the health system in Europe? Thank you.
Yeah, thanks. I can definitely cover the first question. So I guess the power of citizen science is that there's not too many rules. It's pretty well documented. There's a million ways to do it. However, we are working towards a set of guidelines or sort of best practices that we would like to distribute to the entire full community and really allow people to start doing this themselves. Of course, in a structured way, because you need some handles, some guidelines to do it well. And yeah, regarding your question about migration, so what we are looking at is accessibility of care, and one of the parameters there we're looking at is also equity of healthcare. So how easy is it to access healthcare for different patient populations? So you can talk about gender, you could talk about income based. You can also look at how well people are traversed with the language of the country they're in. And one of the things we also like to look at, how easy is it to access healthcare for migrants? So that is something we're looking at, but perhaps you were also hinting at pressure on healthcare systems related to migration.
I think it's a multidimensional impact, but this what you said is very interesting, that you take into consideration such indicators like that. But certainly, I'm not a specialist with that, but I presume that the healthcare system in Europe has changed since the increase of level of migration in, so it influenced somehow, but it is, I think, one of the could be one of the biggest indicators, yeah, maybe, but still interesting to take this into consideration, and take into the research.
Yeah, no, absolutely. It's certainly something we should look into. Yeah, what we generally run into is that, of course, there's a lot of data. The European Union collects a bunch of data. But when we start to dive into more perhaps niche or things that are more related to a single country with respect to other countries, we often run into data disparity. So we can find data for specific countries and we can really make that EU-wide comparison. So that's something we're running into. But thanks for that suggestion. We'll definitely look into it.
And with that, I want to, in general, thank you both again for this very interesting presentation, and definitely continue with the research. We're looking forward this report, and we wish you kind regards here from Poland towards the Netherlands. And with that, we are moving on to the next item on today's agenda with another very interesting presentation, because it is a presentation on, I believe, on rethinking as well how we do health, how we do healthcare. I believe the word is healthing, but she will way better explain it than me. With Ushma from the organization Ripple. Give her a warm applause.
Oh, I cannot clap while I'm holding the mic, but yeah. Hello, Ushma. Can you hear us well?
Yes, I can hear you.
Okay, so now some magic, change of the slides, the slide of hand. And we are leaving the floor to Ushma, I think.
Thank you so much. Thank you, everyone, for all of the amazing presentations, and thank you also to the organizers, Chris and Michelle, for having me here today. I'm going to be talking today to you about healthing forward. We're going to try to together reimagine what mental health could look like, and what that transformation, systemic change transformation would be like. I am referring a bit to Evert's principles around kind of closing the tap. That's kind of the direction we want to move toward today. Before we start, I wanted to kind of create a bit of a philosophical foundation for today's session with me, starting with Einstein's quote on, "We still do not know 1,000th of 1% of what nature has revealed to us." So I'm kind of referring to a bit of intellectual humility that is essential in today's world. We are facing profound mental health paradoxes. In this world today, we have rising awareness, yet worsening outcomes. We have more resources than ever, but a deeper crisis. We have greater connectivity, yet profound isolation. So with a bit of intellectual humility, we want to move toward exploring what the way forward could look like. So I ask you to kind of embrace this humility of not necessarily knowing all of the solutions, but exploring the world with a bit of a learner's mind. So the core concept that we're going to be talking about today is healthing. Healthing we define as a proactive process of maintaining and enhancing the well-being of everyone. We focus here our intentional actions that prevent disease and promote health. This is where you can connect to Evert's presentation about closing the tap. Real world examples here are shown as the City Council, for example, has been healthing by creating more green spaces and funding mental health initiatives, for example, or by producing sustainable products and reducing environmental pollutants, the industry is healthing on a larger scale. It's just examples on how we kind of change our perspective. And the shift here is about moving from a reactive treatment perspective to a proactive well-being perspective, and this is fundamental to what we're discussing today. The scientific foundation to healthing is from Aaron Antonovsky. I just want to tell you a little bit about his story. He was a medical sociologist in the 1970s, and he began his journey with a surprising discovery while studying Holocaust survivors. In that he expected to kind of all survivors to show very poor health outcomes. Instead, he found something remarkable. He found some people, a small percentage, but still a significant amount, that maintained good health despite extreme trauma. So this kind of paradox led him to ask, what allows some people to thrive despite adversity? So his breakthrough insight kind of was about the key wasn't absence of stress, but how people perceived and responded to it. So the solution to his question on what creates health was the sense of coherence, which is about comprehensibility, which is kind of the perspective of I understand what's happening and why. The manageability as well, the second part, which is about I have the resources to handle this challenge. And the third one about meaningfulness. This challenge is worth engaging with. So this kind of revolutionary conclusion about health is not just absence of disease, but kind of creating active resilience. This is the framework of the foundation of healthing as well. So if we look at systems, today we see systems that are out of balance. We have current realities that show fundamental misalignment in incentives. We have industries that profit when mental health kind of deteriorates, unaffordable healthy options across food and housing and healthcare as well. We have work environments that actively sometimes undermine mental health by glorifying overwork or constant availability. We have prioritized metrics over well-being. And also in urban design, we have isolating urban design about how about physical spaces that are designed more for efficiency and not necessarily for well-being. So the conclusion here is that hypocrisy has kind of become a bit of a new normal. Industries champion, I'm over-exaggerating this statement, but industries champion well-being while struggling to kind of find the alignment needed to kind of make that happen as well and find that alignment. So how do we move from here? There is a need for systemic change. We have to transform from a more misaligned incentives to aligned incentives, from where industry wins when people are unhealthy to industry wins when people are healthy. And it looks more from a kind of win-lose situation to a win-win situation. So the way we kind of want to go about it is we have a three prolonged, and this is kind of the idea and also the framework for discussion today as well, is a three-step approach to introducing the health incentivization policy that can also be applied to mental health. And the first step here is about disincentivizing harm, tax businesses contributing to mental health issues, target unhealthy foods, attention exploiting technology as well, unnecessary treatments. Then the second one is to kind of also narrate and shift toward the positive. How do we incentivize and reward businesses integrating well-being into products, services, and environments, and make mental health promotion profitable and sustainable as well? And the third one, of course, is the redirection of wealth toward prevention or toward healthing, supporting community-based healthing programs as well. So this shaping of markets for healthing, the shaping of markets overall is not a new concept. It is being used in the energy transition. It's also being used in the organic food transition that was done in Denmark. There is a lot of papers around policy intervention that have supply-driven policies, but also demand-driven policies to kind of enable that shift toward a more, in this case, for organic, from normal farming in that sense to organic farming, and to kind of enable that transition. The goal here is to replicate this success with mental health as well, make mental health the norm, and the strategy would be to utilize policy to shape markets and incentivize well-being. This transformation or this transforming of environments is really about leveraging the capabilities that the industry does have. So really taking a positive view on what industries can do is to support well-being industries. Also, we live in a very siloed world where we consider healthcare to be only healthcare companies, but real estate and urban design are also in the healthing industry. They contribute to the environments that shape our health. Purpose-driven workplaces, public spaces, and community initiatives as well that can enable this transition. The future is full of possibility. I am an optimist, as you can see. What success looks like is kind of aligning the incentives, making and enabling measurable change, including diverse industries into contributing to mental health as well. And this is kind of what true healthing looks like. It's not about, there are social businesses and then normal businesses, but it's about kind of having all businesses become social businesses and taking responsibility for their impact on people's health. And kind of reimagining Mariana Mazzucato's kind of thinking around every economic activity that you can imagine, or every business decision that you can imagine, needs to include mental health value. So cities, this is of course a very optimistic and idealistic view as well, but I do strongly believe that that is the foundation of transformation as well. Cities, workplaces, and schools designed to promote connection, resilience, and mental health with that as well. So how can you get involved, and how what is your responsibility for me to kind of motivate you to champion this systemic change with an intellectual humility? The first thing that's important is listening, and I kind of circle it back to the beginning of intellectual humility around championing systemic change with exactly this intellectual humility, listening to understand the impacts of our actions. We saw in the presentation before, healthcare systems are complex. It's difficult to answer the question, which is the best one. Every thing is interacted and interconnected to each other. So we need to have go in with a learner's mindset and first of all listen to the issues and understand the intent and then the impact of it, and then understand also what are the levers of change. Advocating for policy and initiatives that prioritize mental health being, innovate as well, become creative in the space that you're in, and then drive change as well. So well, of course, one thing, as I mentioned in the slide before, is as well, it's kind of starts with you. We're talking about systemic alignment of where industry wins when people are healthy. This true kind of alignment that we want to see in systems is something that kind of also starts with you. Mahatma Gandhi said, when what you think and what you say and what you do are in harmony, that is happiness. And I would even argue that that is also mental health. And that is the alignment that we want to see, or that we can work on within ourselves to be able to create that change on a system level as well. With that, I thank you very much for your attention and for the opportunity, and I'm open to answer any questions you might have.
Thank you, Ushma, very much. Yeah, I mean, I'm inspired because we are working with Ushma on some projects with Volt, so I'm really happy. And yeah, I mean, I just give you because
No,
I have, yeah, I mean, I'm just, no, I give you something clever.
thank you again, Ushma, for this amazing presentation. And Thijs and Tom already presented the different healthcare systems, and you made the nice bridge to the topic that we'll discuss in a bit, which is the healthcare system around mental health here in Poland. And you gave us a lot of ideas, and you talked a bit about policy. What would you think would be the first, let's say, policy idea, concrete policy idea for a country to adopt, and that we as Volt could strive for in the political domain? Because just making all businesses, social businesses that take mental health value, as you said, is still very complex to implement. Do you have an idea on a potential concrete policy on this?
Yeah, so I think I'd refer to the work that Denmark has done on their active market development policy and take elements from there. I think the first step would be to take a positive view on kind of shifting incentives for businesses to align their value proposition with mental health, if it's about mental health, and that can be done with a policy to drive supply toward mental health value. And if that is something that would look like a tax cut or a subsidy for businesses that innovate in that space, so it can also be about attracting entrepreneurs to innovate in mental health prevention or in healthing overall, to include physical and mental health together. And then the other idea, of course, would be we live in a lot of elements of our healthcare systems are fee for service in terms of payment mechanisms, and that often leads to overtreatment. And overtreatment is kind of like overconsumption. In some spaces doesn't harm, but in healthcare it does harm, right? Overtreatment does harm, and there to explore policies that can reduce that. And it's about kind of providing disincentives on overtreatment and really targeting care providers. Of course, this is an idea that needs discussing and kind of understanding for the Polish context, how that would look like exactly, but it's about looking at how we can disincentivize overtreatment, perhaps financially. I'm a businesswoman and background, so it's always about kind of connecting the value that we want to see in our world with, which is positive mental health, positive physical health, and then kind of making that financially viable. And how does that look like? I think governments and parties like yourself have the opportunity there to lever financial incentives toward the positive.
Thank you. It's a clear answer for something that we can work on as Volt. Michael, do you have a question for?
I mean, it's like, can I say that you are, because we are actually collaborating with Ripple on some projects, so I'm into this topic, but I don't have like any like urgent questions right now. I'm inspired by Ushma, and I'm like really into this collaboration on creating these policies, and how can we change it? How can we make this helping really the reality? I already started using the verb helping, so thanks Ushma for incentivizing this, and yeah, thank you very much.
I think indeed that is a good point. Already starting using this word, helping, is already a good start. And with that, except if there is a last question, yes, actually, do you have examples of practical quick wins we could achieve in our circles of influence at a more granular level? From a question from somebody watching online.
Yeah. I think the first thing that I would even call a quick win is awareness. Just awareness about the topic of, a lot of times I can speak, for example, from India originally. I can speak from there. There is very common perception of viewing my care provider in a similar light as I view God, right? And sometimes we cannot imagine that a care provider might not necessarily act in our own interest. Just the awareness of understanding that there are financial mechanisms that lead our decisions, and that our providers have, to be honest with you, struggle with the conflict of acting in the interest of the patient or kind of in their own financial interest. That dilemma, kind of being aware of that and talking about it, and ideating with your community about what we can do about that, I think that would be a practical first step. It doesn't sound like a first step, but I think not talking about the critical kind of conflict of interest that we sometimes struggle with is the biggest issue, I would say, is the foundational issue. So kind of talking about it and being aware of that I would say is a practical quick win.
I think in general with the mental health care domain, simply start talking about it would already be, talking more about it would already be so much more than we are currently doing. And especially also on this topic. With that being said, Ushma, thank you for your presentation. And we're running a bit over schedule. So I just wanted to announce, let's see how long of a break. Let's do just a 2-minute break. And then you already introduced the topic of mental health care. And we'll then go into the panel discussion here live from Krakow in Poland on mental health care policy here in Poland. So see you in 2 minutes.
Don't be late because we will be angry. No, we won't be angry. No, I'm joking, of course. So yeah, are we muting us or are we still on? Hello again, everybody. Oh, I'm already large, so welcome back after the short break. Right now, I have the privilege to meet with Norbert and Rafał. We'll be talking about mainly mental health reform in Poland. But firstly, I would love if you would guys like to introduce yourself briefly. Maybe if you would like Rafał to tell a bit about yourself, and then I will give the mic to Norbert as well. Thank you.
Hi, my name is Rafał. I live in Warsaw. I am a peer support worker, which means that I live with a mental health condition. I have ADHD, bipolar disorder, and narcolepsy. I've lived a long time in the United States. I've learned the job of peer support worker in California. I moved back to Poland about 3 years ago, and here I work at the F. Kropka Foundation. and at the Institute for Psychiatry and Neurology in Warsaw.
Hi, I'm Norbert Bolek. For 4 years, I've been an educator in F. Foundation. That is a count of 150 workshops on mental health. And also I worked and supported the reform of mental health system in Poland. What can I say? I'm 49, and for 30 years I've had some psychiatric diagnosis, and that's all I think.
Yeah, that was supposed to be the first question that I was going to ask you, right, about your diagnosis, because we would like to maybe first introduce people who are not aware of the mental health landscape in Poland. Could you maybe briefly tell us about your condition, something more about your diagnosis, and what is the landscape of psychiatric help in Poland?
This is a question, I don't know, maybe for 2-hour speech, so I try to make it short and say that my diagnosis was once bipolar disorder, then schizoaffective, then it was schizophrenia, then again schizoaffective, and I got 3 or 4 of them, and then changed in time. But the one constant thing is that I've been hospitalized due to psychosis for 6 times in my life. And it was always it has always been at some large hospital, because the system was constructed this way that the large hospitals and small facilities, when doctors just prescribed recipes for drugs, and the old system was waiting for someone to get a psychosis. Then he got institutionalized and cured and put away from the hospital, and that was all.
Yes, and then there was a change, right? Could you tell us a little bit about this mental health reform that started a few years ago?
Yes, in maybe 2010, national program of mental health system reform has passed, and for 7 years nothing has changed. But in 2017, there was the first mental health congress. And also the program was put into life, and then mental health centers were created. In a pilot program, there were 30 mental health centers all over the country, and the goal is to have 300 of them to cover the whole Poland, but the pilot program was developed and then prolonged, and then developed more and prolonged more, and we are now in I don't know, 7th or 8th prolongation of this pilot program, and we can't wait for the reform to get into life.
Thank you very much, Norbert. And I will now ask Rafał, because you are peer support, right? Mm-hmm. And you are actually working in the mental health center, right?
Yes, I do.
Yes, so, yeah, yeah. So could you maybe for people who doesn't know, what does your job incline? What is it based on? What are the main like assumptions behind it? And what is your job as a peer support? What's the difference between your job and like a doctor, for example? Because you are working with patients, right?
Yeah, yes, I do. So the hospital is divided into clinics, and clinics are divided into wards. And also attached to the clinic, there's a mental health center, which is what Norbert was just talking about. My job is between one of the wards, the general psychiatry ward, and mental health clinic. No, mental health center. My work is generally divided into two parts. One is individual meetings with patients, where I provide support, psychoeducation, general conversations. Sometimes people just need to talk. And I also run support groups. I run support groups for patients and for their families and loved ones, different groups. I consider myself being part. I consider myself being part of the team, a care team that's around every patient, and that team is consisting of a medical doctor, a psychiatrist, a nurse, psychologist, and a peer support person. And I sort of glue this whole team together in the sense that the patient who is in the middle may have questions about his medication, may have questions about his work with a psychologist, may don't know where to turn to get certain support. And this is where I sort of come in and try to educate them that, you know, that kind of support you'll get for a psychotherapist, and for medication you go to a psychiatrist, and so on and so forth.
And as far as I'm concerned, the po angielsku, the occupation of peer support was not present before the reform. So, Norbert, I have a question. Could you like explain to the watchers and to people here, like, what's the gist? What's the main difference? What shifts? What was the main change that was supposed to happen with the reform? Not in 2 hours, but maybe like in 5-10 minutes. Like,
okay. What happened was, but it didn't happen in the whole Poland, because we're talking still about the pilot program. What happened was that the care was close to the patient. It was in his community, in his neighborhood, and also. He works in mental health center and also in the hospital. And Rafał, when he knows a patient and he attends his group, or maybe feels a little worse, and goes to the hospital, when Rafał also works and sees the patient in this situation. So we don't lose the patient to the hospital when he's closed and nobody knows what is going on with him, because the center also works in his neighborhood and also has a psychiatric ward that, when needed, also cares about this patient. And the center does many things, many procedures that maybe the patient will not worsen as much to go to the hospital, to go to the psychiatric ward. Maybe we can help him earlier and more efficient just in his community or neighborhood.
thank you. And I know that this is not the reality, but correct me if I'm wrong. As far as I'm concerned, the main idea behind also the reform was the change of paying per the bed, right? So the incentive that if the patient, the hospital is getting paid by the patient who is sitting in a bed, to the financing of the area, right? So the mental health centers, you already want to correct me. Okay,
Yes,
go on.
because it pay per procedure or which may be I know bad in hospital or I don't know something different, or pay for the population. So the mental health center in the idea of the reform got money for the population when somewhere he has to cover 200,000 people. He had a certain amount of money for this, and the center can decide which means are most effective. We know there are areas that we should care about, I don't know, alcohol use, or there are different areas that we care more about, I don't know, young people that come to depression or something. So that's my correction.
Thank you very much. And going back to you, Rafał, I have a question because you said that you are like working in a circle around the patient, and I wonder because you have different relation with the patient than the doctor, right? And it also, I wonder, can bring some moral problems, like because, yeah. Do you want to share maybe tell us something more about this?
Let me just say one other thing that Norbert was talking about here is that the large portion of the reform is to move away from the hospitals and move into the communities. So everything that Norbert is describing is working within community rather than dragging the patient into the hospital, locking them up, and then trying to, in parentheses, cure them. All right, so my conversations with the patients are confidential, but they're also very, very personal and very, very intimate. And that level of intimacy is achieved because the patient and I are in the same boat. We both have diagnosis. We both lived with them. We both live with them. We manage them somehow. I was in a hospital at some point in the past. I had suicide attempts before in the past, and so does the patient. So the patient, when she talks to me, finds a peer. We have similar stories. Therefore, she can be a lot more open with her story to share with me. Now, what do I do with this story? Well, I support her as much as I can. However, if I find something in what the patient is telling me, I can share it with a doctor, or I can share it with a psychologist or a nurse. The confidentiality stays within the team, not just between me and the patient, but within the entire team. I wouldn't tell you what I talk about with the patient, but I will tell her physician, her psychiatrist. So that's kind of how that works.
Thank you very much. I have a question to Christian. If there are maybe any questions on the chat for us. Right. Do you want Norbert to add something, or do you want me to come up with a question? Other.
Maybe one question from you.
Right. So, could you maybe, because we were talking before, and now I have a blank page in my head, because you said already about the reform, the change of the reform. Maybe can you bring us into the actual state of how the reform looks like? What are the possible futures for this?
The answer is we don't know yet, and it's hard to say. And what are the other expressions similar?
Nobody knows.
Nobody knows. Yes, very, very, very nice. So there are problems with this reform to go on. Because there are because of politics really, and the urge of politicians to give simple answers. And the reform is very well projected. Together with Rafał today, we studied almost ready bill for the reform. Rafał was angry because it was very difficult to understand.
I'm sorry.
And it's already been overthought. I don't know, maybe it was overthought, yeah. And there are few ways to end this, because this is a pilot program and it's about to end, and there are ideas to come back to the pay for the procedure, which we think would be deadly for this reform, because not everything can be a procedure that is refunded by the state, and we all the time we are waiting for some statements from the government and for some final words or final bills that are coming, we think.
I just want to add that again, Norbert's absolutely right with everything he says. I like to simplify this to, it's not really all truth, but in some places, in some means it is. National Health Fund is a single payer insurance company in Poland. It's government owned, we pay taxes, and the taxes pay for our healthcare. But in effect, it is an insurance company. And like any insurance company, wants to take in more money than it spends. Consequently, it makes cuts wherever it can. And it thinks, just like Norbert explained, that we're spending too much money, that this is too expensive. So they're trying to figure out some roundabout way to cut the spending. Yeah.
And I can also imagine that, because you can also say who was the creators of the reform, but it was very innovative, right? And as far as I've overheard, or I think that that's also the case, that after those several years of the new reform, now there's this pushback of the old system. Like it's not that easy to change that. What we were speaking before, like the presentation on the European level, that bringing the changes is really difficult. So yeah, could you maybe some of you tell us who were the inventors of the reform?
Yes, the Holy Trinity, or three tenors, as we say. Professor Jacek Wciórka, Professor Andrzej Cechnicki, and Dr. Marek Balicki. That were the three creators. Yes.
And as far as I'm concerned, oh, hello, Evert. Evert is. Oh, go on, Evert.
Well, first of all, I love this movement out of the hospitals into society. And sometimes in the Netherlands, there are also attempts to do that. And often they say this is difficult because the people that get back out of the institutions into society have a distance to society. Now, in my view, it is not merely people having distance to society, it is society having distance to people. So I think we should invest in society to get better connected to all kinds of people, including the people who enter society with mental problems. And I'm wondering how the two of you view that.
Yeah, I can just say from myself that I'm also diagnosed with bipolar. I was also hospitalized. So this idea of stigmatization is very much in my life as well. But yeah, maybe. But I know that also Norbert wanted to add something. But maybe I don't know who should.
I second that. I second what you just said. I think the investment needs to go both ways. I think there is a certain amount of, there's a lot of stigma towards us. There is also a lot of fear, and that turns the society away from us. So, and we're scared of the society because we don't know how they're going to treat us. Just because I have this condition, who knows how they're going to treat me? So you're absolutely right. It works both ways. We're trying to invest in our health, and what you're saying, the missing piece, investing in society, is necessary. The foundation, our foundation of Kropka, does exactly that. And maybe Norbert, you can tell more about our workshops.
No, I'd like to say that the most important thing when you think about stigmatization in this reform was that every mental health center had an obligation to employ peer support and or expert by experience, as you tell, that helps the whole team to treat the patients, and that was good for the people that were experts by experience, but also it was good for the surroundings in this mental health center that even them then there it fought stigmatization or stigma. Because Rafał works hand by hand, hand in hand with doctors, nurses, or other personnel in hospital or in mental health center.
We also, both of us actually, and a lot of people from our foundation are, we go to the media, we go to television, we go to the radio, we're being interviewed, and our strength is in the fact that we don't hide with this illness. We openly talk about it. We turns out that when I talk about people looking at me, said, "Oh well, this guy looks normal," and yet he says he's got this thing, and that's how we tend to fight stigma. That's probably the most powerful way to fight it.
Can I reply to that?
Yeah, sure.
Because when I look at the two of you, I don't see two people with an illness.
Right.
So if you get on television, people will see two normal people, and that will probably not help them relate to the actual people that they come across that do have mental problems. I think the main thing is that people have fear for things they don't know and for people they don't know. So a major element of getting society to get less distance to people is to let people know each other. So get together, talk to each other. I think that is a very important part of bringing these worlds together.
Yeah, thank you. And that's what Christian just said behind the curtains. That's the event. And I would also add some different stone to the puddle. How to say? I'm not sure if I'm using this correctly. That there is stigmatization, and in my case, it was also very auto stigmatization. So I self stigma. So I never actually had anyone talking to me told me that I'm crazy, but for me it was because I'm also it helped me to talk about mental health because I'm running foundation. I'm having YouTube channel where I talk about mental health. It helped me to auto therapy. It's in an auto therapeutic way, so it helps both way because on one hand it helps me to become more self-aware and happy, and also educate people other. And I think it's very important that we have this meeting, this event, and we talk. This is great what F. Kropka does with the workshops that Norbert doesn't want to tell us.
Okay, I just say that workshops are about education on mental health, and we tell our life stories and our healthing stories, and also we have different give yes, they give the participant, but what do they give? They give the tools. They give the tools to communicate with people with mental illness or suffering from such illness.
I am aware of the time constraints, so I wonder we can continue because are there any questions like in the room? Maybe. Oh, there's a question. Yeah. Would you like to come to the camera or would you like to stay?
We'll stay, okay. Is that okay? Hello. I would like to ask about peer supporters, as I know, like just like Norbert said, it is a well projected reform, but I also know that peer supporters in Poland are unique because they are hired by public service, right? So this is unique in Poland, and I would like to ask if there are any other things in Polish reform that are unique in contrast with other Europe countries.
Who would like to? Oh, there's Norbert already.
We didn't make any study. You should study that. Different cases in different European or not European countries, but we hear a lot of good about psychiatry in Finland. I like to say that the whole open dialogue that comes from Finland is a very interesting thing, and there are different kinds of engaging the peer supporters in different countries.
I have a question.
Okay.
Maybe to Rafał, because I am aware that znowu zapomniałem słowa, zawód, the profession of peer support is quite weird because it's actually there's some difficulties with setting this as a profession because this is the only profession, I think, as far as I'm concerned, which is not everybody can become a peer supporter because you have to have a mental health crisis before, right? So I wonder, like, if there are like any other problems or wyzwania, challenges in your occupation that you would like to talk about us. What are the changes that are good, bad?
First of all, what I want to say that there is 4, 5, 6, 7, 8 of us here in the room. 4 of us are peer support workers, and at least 6 of us are experts by experience. What are the challenges? Challenges are emotional, very much so, because the stories that I do hear in the course of the day can be very, very challenging. At the same time, I have to be empathetic towards the person that I'm speaking with, and that can be a huge challenge. The situation that's very challenging for me is I lead these support groups for families and loved ones, and those are extremely difficult because as I talk to a person, I have 2 tragedies in front of me. The tragedy of the person who is sitting in front of me, whose son or mother or loved one is also ill. So there are 2 tragedies sitting on top of one another, and that can be extremely difficult. I find support from colleagues in the ward. My office, I share office with psychologists, so I can always get support from them when I feel that I need it. I have my own psychotherapist. The model of healthing that I follow is medication and psychotherapy and self-care. So I follow that. So that's my support. and everything that I can do for myself. I go for walks. I have my hobbies. I uh, listen to music.
You are an actor also. You didn't have said it before, and director, right?
Yes, but well, by trade, but by education. But I don't practice anymore.
Okay. Christian is pointing fingers at us. I'm not sure if he's angry or no. What do you want? Are there any questions? Are just
I want to thank Norbert and Rafa for these very interesting discussion and telling us more about the Polish healthcare system. And yeah, again, also for inviting us here tonight in this beautiful city, Krakow. Our idea now was to go with two new online speakers to a closing after talk about everything that was discussed and see what both in Poland but also on an European level what we can do on improving health but also improving mental health. So I would like to ask you back to the podium and give them again a warm applause. And now I will bring.
I'll just say that I would like to also thank F. Foundation for the guests that they brought within, and I will leave the floor to.
I still see Madalena still muted herself. And I see Sue as well. Can we quickly test the audio? Sue? I believe we can hear you. Or not. Madalena, can you quickly test with us the audio?
Yes, can you hear me?
Yes, perfect. And Sue, is it working here as well for you? We can't hear you.
So now?
Yes, we can. Amazing.
Okay, great.
So we're now in the last point of this session here online and in Poland. And Evert already gave a starting presentation to set a bit the scene of the topics that we're discussing today. Afterwards was an amazing presentation by Citizen Research Project on the different healthcare systems across Europe, and then Ushma went into the concept of healthing and mental health care. Marlena, I believe you followed the whole session, and Sue, you just arrived. First of all, could you both introduce yourself really quick for the people here and the people who are watching from home? Madalena?
Yeah.
You can go first.
Hi, everyone. I'm so excited to be here. I'm a student of European Affairs and Social Policy, and for Volt. I am a policy shaper on the area of health and social care. Yeah, very brief.
Very brief. Thank you. And Sue.
Yeah, I'm here located in Germany. I'm right now in Berlin. I have attended the whole session, so I have everything here on the list already. So I was there from time zero, so more or less. And yes, I am just very, very new into the field of HealthCom now at Volt. I'm working, or have worked in the last election as a candidate, especially on a local basis and on the themes of health and also social care in Germany.
Thank you. And thank you for the introduction. Towards Madalena, the question from everything that you heard so far with the presentations or the panel here, what is, let's say, your top two things that will stick with you and you think like, oh, this is something we need to work further on as Volt in the political domain?
Okay, hard question. As I said, I'm very excited to be here, and I hope to be able to work closely with all the speakers here. Yeah, I think the first point would be that this event really reminded me of the idea of Polanyi's idea of like the fact that we are living in a society where the society is embedded in the economy, and we needed to we needed to make sure that the economy becomes embedded again in society, and therefore, and this can be done and with through what Ushma was saying, with aligning incentives and making sure that, and also Evert's idea of participatory action research. So the idea of creating policies that are centered around people and not only individuals, but the entire community, as we heard also with the last panel. And this ensures that also policies are efficient in the end. So we can also talk about efficiency because they are really adapted to the needs and also the reactions of individuals and in particular communities. And to be brief, and then this is also connected to the fact that we needed to ensure that health is taken into consideration in all different policy areas. So we have to have a more holistic approach to health policies, and this is necessary both for physical and mental health. And the second point that also stuck with me was also the fact that we needed to have policies that are based on data and research, and they're based on data and research that comes from individuals themselves and comes from the communities. And also this, I thought it was also very important to mention how to connect research to individuals and to people who are not professionals, so that, and by ourselves or politicians connected to people, then we can bring research to politics and to policies. Yes, those were the two main points. But there are a lot more than I could talk about, but we have limited time.
Answer. And now towards you, Sue, as we told the audience from the start, you and Michael were picking up the initiative role for building this health community within Volt, but also hopefully outside of Volt. Besides, let's say the policy talk, what do you see are some concrete initiatives that we can build further upon, that we could promote? And also actually the same question for you, what were, let's say, 2 points that you really will take from these presentations and panel discussion today?
Yes, I have seen, and it has become increasingly clear to me that our political initiatives require stronger coordination with partners from the private sector, civil society, and NGOs to effectively achieve the intended objectives. And one of the key goals of our upcoming activities, which we plan to implement within our district level party work, is a monitoring system as outlined in the research contributions. This will provide a solid foundation for increasingly targeted efforts in addressing the challenges of healthcare prevention. Furthermore, as we learned impressively in Ushma's lecture, it's also about overarching responsibility and the transformation of a healthcare concept within an interwoven framework of economic, social, and individual demands. But this also sounds as a broad and very wide concept. What I think is we have to we have to emphasize on this view from the individual, but also the individual in this network that it has its activities. And another crucial aspect is to highlight the dynamic structure of the field in which we operate. Across Europe, we are witnessing a sharp rise in mental health issues among younger population, often directly linked to technological advancements, environmental challenges, and shifting social structures. And yes, and the connection of the healthcare sector needs to be far more clear to each and every individual, that it's an environmental, that has an environmental impact, that it cannot be viewed in isolation, and it needs a stronger European view on all of this. And yes, another point that I try to figure out is also that we need to engage more also the global frameworks and foster international cooperations, such as those established in tropical medicine institutes and particular and also regarding preventive measures against epidemiological challenges. This is something that we have not mentioned, but it's also an outcome of all what it has mentioned before. So we need to have this broader connectives as well. So from the point of the individual into the system, and also to a wider and broader network. This needs to be our route, more or less.
Thank you. One of the comments in the chat during the event, we couldn't really touch upon the question that was asked there. The question related that towards that at the moment, healthcare policy is not something that is being regulated on a European level. It is on a national level, and now we learned of this great policy direction on the Polish level around mental health care. Would you say, and do you think we as Volt should argue for that healthcare would become fully or partially something that we do on a European level, where, for example, this good example of mental health care in Poland could be, let's say, also sent towards other countries?
We have the possibilities because in all this researches that we have seen, we have already the evaluations, and we have also already the basis for this, for working more into it and bringing it into a wider net, more or less. And I think from each country that we are working in singular projects, we need to have the evaluations that gets into a basis for establishing this European healthcare system, because it's not something that you can see isolated, especially when it comes to pandemics, especially when it comes to economical and social and environmental issues. So you cannot really cut the one findings out of the whole progress. So you need to have also a European basis. So you always have to have this inside, to have this in focus, I would say. Mm-hmm.
Yeah, and I think this is like the first health community event, and I'm really happy that we will be trying to create something on this European level. We spoke before that health is, I think, one of the most difficult thematic communities because it actually revolves around human, and humans do everything from the health, from digital. I mean, there's like air quality, there's like there's mental health. With you regarding the different topics. So I'm just like just point that it's a big challenge for us. There is not a solution on the European level right now, and I'm really ambitious and happy that we'll try to do something good here. And thank you, Christian, again for helping us make this event and this community.
Thank you, Michal. Now also towards Evert, you started with setting the scene for this event. Do you have some last words from your side?
Well, throughout this 2-hour session, there is a statement from Harvard professor Shoshana Zuboff that keeps bouncing in my head. What she said is when you become ill, you start as an individual, then you become a patient, then you become a disease, and you end as a bed. And the performance of hospitals is measured on how many beds are filled. So when we talk about, when policymakers talk about the health, they talk about finance, insurance, efficiency, etc. And I think this session made clear that the human should be at the center again. And when it comes to taking action to put health on the European agenda, I think that should be that there's a great chance for us to put that as a center of that policy on the agenda. And the whole idea that Ushma talked about healthing, I think that is a very important element, because then we start to work towards healthy communities in which disease is only part of the story. And when we get there, we get much more health, we get much more welfare, we get much more happiness in the world.
Madalena, as you're working in since recently in the European policy team of Volt on health, as Evert said, putting health on the agenda. Is there already an idea to just make a policy saying like the word healthing, or any other closing remarks for this session?
Thank you. Well, to be honest, we are brand new. We just met for the first time last week, so we haven't started yet with like a project. But I think this was the perfect way to start, to have like all these insights from all these amazing people, and to be able to really develop policies from what I've heard and my colleagues also heard in this event. So thank you very much.
I think that was some good closing words from Madalena.
I wonder if there are any closing questions, statements from the audience here. Oh,
I don't know if you heard some applause for from the Polish side here.
Oh, there is a question.
I have a question. If Volt will implement the Polish mental health reform in the whole Europe when it comes to power.
When?
When?
All right. I will be diplomatic. I will send as soon as possible.
I think the people now in online would agree with us that it is something, a mental health care system that we definitely would, or a version of it, put in our policy program for a next round. I don't think it was in our last moonshot program for the European elections, but it is definitely an policy, I think, that we'll further explore and look into, and probably would campaign on if in the next election. Of course, we can't make promises, and none of us here is at the moment an elected official for Volt, but who knows in the future. So we at least learned today about this system, and I think we're very intrigued by it. Then truly with that, I want to thank you all. I want to thank the people here, the people online, also Rick, Tom, and Thijs, Tom, and Ushma back in the online backstage, and Evert, Audrey Sue, and Madalena for joining this after talk. And with this, really want to thank end the session, but I believe Michal has some true final words.
Yeah, because believe it or not, as far as I was the idea generator for this event, there was a time when I really wanted to not make it because it was beyond my capacity. So without Christian, I'll have to say that he's a mastermind of, if you would be able to see the cable connections there. It's impossible to imagine really what he's done. He's traveling all across Europe. He just came to Krakow yesterday. He's a mastermind behind this, and his energy is really inspiring everybody. So thank you, Christian, for making this idea reality. Thank you very much.
And with that, I am taking this stream offline at the moment. Thank you. Have a good evening.